So basically she came with a lung disorder, and what we shall see is first the lungs. So as you see, these lungs are they were little heavy in weight, and it has these kind of scars, and there were subpleural accentuations and perilobar accentuation. This I am telling you just in context of typing of ILD, and we do not see any fibrocaseous area, thereby kind of excluding the presence of tuberculosis, and there are no dilated or bronchiectatic areas to consider cystic fibrosis in this context. There are these kind of areas of honeycombing which were present both in upper lobes as well as in the lower lobes, thereby indicating that there is a presence of ILD, and one lower lobe had this solid area which was likely because of infection. So as you see, there were subpleural areas of involvement and paraseptal areas of involvement where lung is quite distorted, it is dilated, air spaces are there, and this kind of a honeycombing with mucinous metaplasia is there, along with presence of architectural distortion, which is confirmed by Masson's rectum stain, which picks up fibrosis. And there was a spatial heterogeneity. Some areas are involved and some areas are perfectly normal. These changes I am just mentioning because in context of typing of this ILD. And as we see, we don't have any evidence of granulomatous pathology neither for tuberculosis or for sarcoidosis. We were trying to look out for any, any histomorphological clue towards presence of ILD, but they were not present in this case. There were fibroblastic foci in some of the areas, and if we see all these changes which we have seen are typical of usual interstitial pneumonia, which is one form of ILD, and lower lobe showed evidence of infection in the forms of neutrophils within the ear spaces, so, though no organism could be grown within these areas. So as far as lung is concerned, we established it was an interstitial lung disease of UIP type, usual type, whereas there was no etiology for this as far as morphology was concerned. Now having look at the liver, which is the organ of concern today, if you see this liver was 1000 gram normal in weight, but you can appreciate some kind of nodularity which is present, which was probably appreciated on ultrasound. The gallbladder is normal, which tends to be atrophic, it was cystic fibrosis, and so is pancreas, which is normal, which again should have been abnormal if it was cystic fibrosis, and spleen seems to be in within normal range 160 grams, so there doesn't seem to be an element of portal hypertension present as yet, but definitely our liver did not look okay. Even on surface you can appreciate these different size of nodules are present, they are vague but they are definitely there. Closer view you can appreciate this kind of nodularity as you try to see it closely within the at a closer look. This is the portal vein which was patent, and so was the hepatic vein. So at low power what I am trying to show is, though we are not seeing nice good cirrhotic nodules, but some kind of vague nodularity is appreciable. You can see these nodules being there, this one, and no scarring. So when you have a closer look at these nodules, you see there are bigger hepatocytes here and smaller ones here, but no evidence of any fibrotic bands which are causing these nodules. The stains were done, pleuritic stain, which just highlights the absence of any fibrous strands, but you see the difference in size of these hepatocytes at the periphery versus center, thereby indicating to us that there is something which is to do with the vascularity of this liver. Occasional septa like this were present, but they were just occasional, I would say. And another point to be noted is the distribution of portal tracts. It's not very regular as we see. Normally they are supposed to be having a nice spatial arrangement, but here we see some of them are too closely placed and some of them are almost invisible. So these kind of changes do speak in favor of PSVD, and as you see here, I would show you one nodule at a closer look like this one. You see the hepatocytes, the cords are more than one cell thick and peripheral atrophied hepatocytes. So obviously this is indicating that there has been some vascular abnormality resulting in some regeneration. So it indicates that there was some evidence of nodularity because of some vascular abnormality. Now we have to look at what was the cause of this. So for that we will have a look at these portal tracts. So whenever there is this kind of a nodularity which is happening, the peripheral hepatocytes, they show this kind of a metaplasia. So we can see CK7 being positive in peripheral atrophic hepatocyte. This is just to show a septa, which is incomplete septa, which is one of the features of PSVDs, and these kind of atrophic hepatocytes at the periphery. A normal portal tract, as you see, should have a portal vein which is larger than hepatic artery and bile ducts, and there should be one in most of them. About 1/3 of the portal tracts may not have portal veins, and about 10% of the portal tracts may not have bile duct or hepatic artery visible at one point of time. But in this case, as we shall see, there are many portal tracts which are hardly visible to us. Only on doing special stains we were able to pick them up, and in some areas you see there is a lot of fibrosis, lot of new capillaries being formed within the portal tracts, and some kind of a cirrhotic nodules also getting to form. This is something which is normal, and this is where the fibrosis of a portal vein is happening, confirmed on this Masson trichrome stain. And now the minor features of PSVD, there are multiple arterioles which are multiple venous channels within the portal tract, which we also call angiomatous transformation. There are these kind of a sinusoidal, there is a herniation of these portal veins outside the portal tract. Like you see here, normally portal tract should have a portal vein within it, but you can see here herniated one here. A very small portal tract which could hardly be identified. It was only special stains that which picked up. Then there is presence of these kind of a multiple dilated sinusoids were there. I'll just show you. Multiple arterioles, sinusoidal fibrosis which is present at multiple areas. So these kind of a sinusoidal congestion and fibrosis which is present, dilated these kind of a sinusoids, red RBCs within them, fibrotic obliterative portovenopathy being elaborated, EPG confirms it. So we had all the changes which what are described in a portal sinusoidal vascular disorder. I showed you nodular regenerative hyperplasia, flebolsclerosis was there, and incomplete septa. Even other changes like sinusoidal dilatation, megasinusoids, the sinusoidal fibrosis, central vein dilatation was there. There was herniated veins, there were angiomatous transformation, and portal tract remnants which were very difficult to identify were present. So what we have seen in this liver are almost all the changes which has been described in this article, which is a key article on PSV. So now the point is, how do we connect them? Sir has very nicely come to this point that whether we can connect our pulmonary fibrosis with liver fibrosis. So obviously we had to look out for this. For this, tests were done for establishing the diagnosis, because there are some case reports where lung fibrosis and pulmonary fibrosis have been linked by this telomere disorder. So as far as worker for ILD was concerned, we did mutations for MAC5 fusions, which is supposed to be present in cases of ILD. In this case, there was a homozygous alteration which was seen here. So that was not very significant. In addition, we found on whole exome sequencing there was this mutation was present in a heterozygous form. In addition, what was done was to establish telomere length disorder. Peripheral blood of this patient and control were tested for the telomere length by flow fish. And as you see here, in this case, against a normal of 3.14, this patient had a length of only 0.11, thereby establishing the fact that this was basically a telomere biology disorder which has affected both the lungs as well as liver. And I shall show you some more organs which were really not manifest, but the fibrosis was present there also. So thereby just trying to make a point that these kind of disorders can have multisystemic effects, and we need to keep them in mind when we have a patient where we see multiple disorders and we are not able to pinpoint the etiology for that. So just to complete the workup, spleen showed normal morphology. There was no portal hypertensive changes. Pancreas did not show any evidence of cystic fibrosis. Heart was normal in weight. The chambers and valves were normal. However, there were patches of this kind of interstitial fibrosis which was present in multiple areas. This is normal cardiac myocyte and these are areas of fibrosis which was present, confirmed by Mason's trichome stain. Coronaries were dissected, but they did not show significant luminal occlusion, and it has been shown in various studies that telomere disorder can affect and have fibrosis in heart as well. Kidneys grossly normal, and cut section also normal. Microscopically, though not very obvious changes, one could have just passed them as arteriosclerotic changes. But look at this sinusoidal kind of a dilatation. Here we have PTCs which are abnormally dilated for no cause. Generally, these kind of a dilated peritubular capillaries in a kidney are seen whenever there is a renal vein obstruction. But in this case, there is nothing like that, but still we are seeing what we were seeing, almost synonymous what we were seeing in the liver. So this kind of a abnormal dilated capillary channels which have not been described in literature could be seen here. So this is the beauty of autopsy. Though it has never been described, but if you take, when we were just comparing different organs, we could pick up these kind of findings, and there were some changes of a glomerulocystic glomeruli were also there, which is also not a routinely described changes, and some areas in the kidney did show this kind of a there was fibrosis and double contouring of the basement membrane. So that means there was some effect on the kidney as well. GI, the esophagus and stomach were normal. Some dilated capillaries could be seen, though they were not symptomatic. There is no evidence of IBD in colon. However, there were some dilated veins in the submucosal areas. Skin, testes and thyroid were normal. Skin is also known to be abnormal in cases of telomere biology disorder. There is some disc congenita present, but in this case morphologically we could not confirm it. Bone marrow was hypocellular for this age and platelets were low. So another component of telomere biology disorder is hypoplastic bone marrow. So in this case we had only platelets reduced in absence of any cirrhosis. So maybe this was also part of the whole disordered biology. So in this case, finally this young male had TERT mutation and telomere shortening disorder, which has resulted in an ILD as well as portal sinusoidal vascular disorder. Almost all morphological changes were there, along with some evidence of chronic ischemia in the heart and some alteration in the liver as well as bone marrow, which could be part of it, though they have not really been substantial enough to final diagnosis. Thank you.
Thank you, Dr. Ritambhra, for an excellent CPC. I'm sure this would generate a lot of questions. May I request the pathologists also to participate? We have one in the sitting here. And Dr. Ritambhra, I always felt that short telomere syndrome leads to cirrhosis, and this was a part of discussion which happened with Dr. Patrick Kamath about 2 years ago, for identifying patients with cirrhosis with family history and none of the etiologies being present. But I'm happy that you have described it in patients with systemic vascular syndrome as well. Yeah, Rakesh.
Thank you, Dr. Ritambhra. So the particular mutation or variation that was seen, is that a well-recognized pathogenic variation, or is it a variation of uncertain significance? Do we know anything? And what is the association with liver disease for that particular variation?
So we are talking about mutation in MUC or
the one that you showed us.
So that was basically telomere shortening is measured,
Before that, you showed us a A to
The
G
term-
heterozygous.
So that has been, in literature, that has been reported as not significant.
Right. So,
Yes.
so that we can't say.
Yes, yeah.
So coming to telomere shortening,
Yes, sir.
I may be totally wrong. My concept is that as a group,
Yes, sir.
people who have telomere shortening have more, changes of aging in different tissues, and again that can vary from organ to organ.
Yes, sir.
So this telomere shortening that we saw, which organ is this from? Was this true only for one organ, or did we look at multiple organs? And are we at a state of knowledge where in an individual, if we see shortening of telomere, we can say that that is quote unquote responsible for or even associated with the disease? My understanding, of course, it's somewhat old, is that we can't.
So this telomere shortening is assessed in peripheral blood, and that is the way it is. It is a flow fish is the technology which is used, and this reflects the overall biology, not specific to any particular organ. Normally, telomeres are supposed to be maintained, but with aging they are supposed to be shortened. But in these cases, because that's why a normal control was done. So as compared to normal control, it is markedly shortened.
See, normal control. What is this normal control? Is this a SIB? Why? How is this a specific control?
Any lab control. That is that is the way it is done.
Yeah. So that is just to make sure for the day-to-day variation in your testing technique.
Yes, sir.
Right. So, but are we at a stage in knowledge that we can say that this telomere shortening has something to do with changes seen in his lung or liver or anything?
That is what literature has shown. There are large studies where this telomere was measured over, I think, 900 patients.
No, as groups, I'm totally clear.
Can we stop this conversation?
In one patient, I don't think there's a way of connecting them.
First, look, Anand. Look, Anand has a comment there.
Yeah, sure.
Firstly, I'd like to acknowledge that the diagnosis of PSVD in this case was suggested by Dr. Supravat Giri. So, thanks to you, this possibility was included. And I was also convinced that this could be a possibility because we had written a review article on PSVD and why this nomenclature change is important and why it should not be used. Anyway, I did consider short telomere disorder, and I projected one slide to show the rare genetic disorders which can cause this. But whatever case reports I got, all the patients presented much earlier in the life. This patient had presented almost in the 5th decade. That is rather late for these patients to present. But I'm thankful. Every autopsy is probably an ultimate learning experience, and often it shows the limitations of clinical analysis. Thank you very much.
So I think I think we brought this case for CPC here in an ASL was for two reasons. One is to discussion about PSVD, and the second was for the TBD, which is the telomere biology disorders. So after this case was discussed in PGI, and at that time also we had looked at the literature. There's a great amount of data which suggests the relationship between telomere biology disorder and liver disease. And in liver disease, it's not only cirrhosis. We went on to see the association of TBD with PSVD, and there are cases where people have described the telomere biology disorder being associated with PSVD-like changes as well. That was one. To the extent that, let me share one more case, and this was the second case. We had a patient who underwent simultaneously liver-kidney transplant at our center, and post-transplant, he continued to have pancytopenia, and we were not able to explain that. And we were thinking it was drug-induced, he was on MMF and all that, but finally underwent bone marrow, which showed hypocellularity, and we did a whole genome sequencing in that patient, and turned out to be having telomere biology disorder with TINF2 mutation, TINF2 mutation. So what I'm saying is that, and that patient had again renal fibrosis and liver fibrosis to the extent that he underwent liver transplant. So all the spectrum of liver disease have been described with TBD, telomere biology disorder. cirrhosis, chronic liver disease without cirrhosis, PSVD, NRH, everything. I think we have seen that literature in detail. So as I said, the purpose was to teach everybody here about PSVD and the telomere biology disorder.
Wonderful. Thanks, Ajay. Madhumita.
Yeah, the point we wanted to make forward here was this is portosinusoidal vascular disease without portal hypertension. So that is even rare. So we are not certain whether these changes of OPV and NRH, whether they will actually progress to cirrhosis later. So if you're associating it with TBD, associating it with the previously described ILD, then these cases have been described before, but with non-cirrhotic portal hypertension. But this is here PSVD, probably picked up at slightly earlier stage. Maybe over time it would have progressed to portal hypertension. It's difficult to say. However, about the TBD, I'm not so sure whether this would meet criteria because the exon 9 variant is not well described in this subset, and it's a variant of unknown significance rather than not being associated. The telomere length, of course, is something that could be associated. Thank you.
Shiva.
Yeah. My just comment was, AC, you had mentioned PSVD as unrelated to the ILD. And I think that is quite valid because normally if you just see that patient clinically, a diabetic patient, and you look at that liver and those LFT and those platelets, you'll just say this is silent compensated cirrhosis.
Yes.
And there's simply no way that one would suspect PSVD short of a liver biopsy. So, also in this situation, in your clinical algorithm, it was unrelated to the ILD.
That's true. That's true.
Ma'am, can I just ask you one thing? As a pathologist, I don't know whether there are any pathologists in the group, but, oh, okay. Shall I hold on? You want to ask first? No, just as a query, would one have thought with this kind of a morphology, would one have thought of a regressed cirrhosis? Because you could have vascular alterations even in that. So, and he was a compensated CLD. So, would one have thought of a regressed cirrhosis in such a scenario rather than a PSVD?
Incomplete septa are, alternative term used for them is regressed cirrhosis only. But there has been, if you see clinically, there has been nothing to suggest cirrhosis in the past. So in clinical context, if you put, obviously, then I can't call it as regressed cirrhosis. Maybe Subrabdi can take the question better.
Yes, I think, yes. First, ma'am, your question is perfect that we can, if we do not have the clinical background, all these features that Madam has shown is absolutely fitting in what has been described as regressed cirrhosis complex. The small portal tracts, resolved portal tracts, incomplete septal fibrosis, sometimes a lobular fibrous septa, herniated portal vein. So it's very difficult to distinguish pathologically between a regressed cirrhosis complex and what has been described in PSVD, except for the fact that clinically this cannot be a cirrhosis which is resolving. It would have been other way around. The other comment that I wanted to make is in continuation with Ajay sir's comment where the SLKT has been done for the patient. I happened to see the liver explant, and peculiarly the liver changes were not cirrhosis, not PSVD. Rather, it is a typical change which we describe as congenital hepatic fibrosis. It's a very peculiar change that we saw in the liver explant of the SLKT patient, which Ajay sir was describing. So all these, I think now the TBD spectrum is increasing, and what we see is essentially portal-based fibrosis, peculiar fibrosis, and different patterns. So I think in future we will test for all these cases.
Subradeep is a young hepatopathologist in PGI and doing extremely well. Rakesh.
Sorry for coming back. What do we call a disease? For any disease. So what do we call PSV disease? It's a very difficult area to say there is some disease, right? Each of us has some fat in the liver. Is that disease? No, we say beyond a certain extent. Here there was no portal hypertension. Here there was no nodule formation. Here there was really, do these changes really qualify for, how much change do you say if present is it PSVD? We are using that term when a person manifests with disease. Here there are no pathophysiological changes. You didn't see any varices, no spleen was the same size. You didn't show us any evidence of portal hypertension in the spleen. should we even call it PSVD, or say there are some microscopic vascular changes? For instance, we were thinking of ulcers and we were thinking of IBD, but then histology shows us not sufficient changes to call it IBD. So to me, I am very uncomfortable even calling it PSVD.
So I think you can correct me, sir, but I think the PSVD may not be disease. We can call it as portosinusoidal vascular disorders. So I think then they usually may not clinically manifest, and this is a histological diagnosis which is made, by the changes which have been described. But moving further, the only thing we were trying to, kind of net in this patient was the TBD, or the telomere biology disorder, and the TBD can cause fibrosis in variable organs. So this ILD, this guy was carrying on with, and the liver changes and some renal changes we found. We thought that this could all be related to, this was all presumption, but we thought that this could all be related to TBD, or telomere biology disorder number 1. And the patient which I described earlier and which Dr. Suvadeep was saying.
Ajay, we have a talk on this later.
Yeah, sure. So what I'm saying is, the patient which we described earlier actually was clinically diagnosis was congenital hepatic fibrosis, decompensated, and then the transplant was done. And then, as I said, he turned out to be having TB.
I think it's very interesting to have a PSPD, and we had talked by Kaushal in this hall only, just after this CPC. So I just want to say that we had seen one patient, a young boy who has a discus congenital skin lesions, has a pancytopenia. He also had lung disease, and he found a DKCG mutation. So short telomere length disorders do happen, but we need to think about it. I think with that last comment by Dr. Sehgal.
Yeah. See, my comment is on association. I mean, as excellent presentation, and both clinical pathology were very good. Now, my only comment is very simple. There is a nodular disorder in the liver on histology, and patient has been on multiple drugs, for last 2-3 years, nintedanib, MMF, everything. And we have a telomere shortening thing. So if you have to say what causes what, to my mind, the side effect of a drug-induced liver changes are far more likely to be there than attributing it to a rare thing like telomere shortening. It is quite possible. But in more like practice, and as you know, what is more common would be, there would be a lot of drugs which cause hepatotoxic changes, nintedanib is there, MMF is there. I think the likelihood of him, having a drug-induced liver changes histologically would be much more common statistically as an association.
Wonderful. Your points are well taken. I think we would learn a lot in the next talk. We are not going anywhere further, probably. Subrat, Dr. Koshi, and Akash, you are the vascular disease persons of the country. So, you have anything to offer in this? In the morning, you were discussing about PSVD.
So I think there are at least two big case series of TERT mutations and nodular regenerative hyperplasia. And it is pretty common. One is by Don Rocky, and the other one is from a multicenter European group, where they have described. So these are something which are well established. I think what Dr. Rakesh Agrawal said, I in fact tend to agree a lot with him. We really don't know whether some of these changes really qualify to be called pathological and significant enough to be called a disorder, disease. And that is why we still don't have a consensus across the world as to whether PSVD is acceptable in the absence of portal hypertension or not. It's a very, very heterogeneous group where you are just including patients who have got just portal vein duplication in some portal tracts, some periportal sinusoidal dilatation on one hand, and on the other hand, you have a patient with full-blown fibrosis with your NCPF with portal hypertension and everything. So I think unless we have a longitudinal study which shows that this group of patients with this morphology on histology evolve over next 15 years, 20 years, 30 years into portal hypertension, I don't think I would be willing to accept this PSVD terminology based on just histopathological changes of no clinical consequence.
Thank you, Akash.